Good morning, George. And it's Tuesday morning, and I am recording today from Rochester, New York, after having the pleasure of having dinner with Dr. David Zulo last night.
Yes, today we have Dr. David Zulo, and the topic that we're going to talk about today is the top 5 things a managing partner should know about his practice. Take it away.
Dr. Zulo has always wanted to be an astronaut, then was fascinated by computers, but did not talk back to him or laugh. So instead, after learning about the human body through multiple injuries as a high school and college cross-country athlete, he decided to be a pediatrician. Welcome, Dr. Zulo. It's a great pleasure to see you on the podcast.
It's great to be here. Thanks for having me.
We always ask everybody, why did you become a pediatrician other than multiple injuries as an athlete?
So it's funny because truly in the end, it's probably the answer that you get over. The short answer is probably the answer you get over and over, is that I always enjoyed working with kids. Right through high school, I had a tendency to work at summer camps and things along those lines. Even in medical school, summer after my first year of medical school, I went out to Colorado and just worked at a summer camp for the summer. So I've just always enjoyed that population, being around them, working with them. And so as I went through medical school, I was pretty certain that was the direction I was going to go. You had a third year, you get your rotations. Already in the back of my head, I knew that, all right, unless something else beats it, that's probably where I'm going to go. I think a more interesting question is, why general pediatrics? Because that was a little more windy of a road, actually. I went into medical school originally thinking I was going to go into pediatric orthopedics. Then that kind of morphed into, maybe I'll go peds general surgery. But then when it came down to picking a residency, I decided I'll go general peds residency, but then maybe I'll do a specialty cardiology, something along those lines. None of them really floated my boat as I went through. And when I finished residency, my intention actually was to do a primary care sports medicine fellowship. Because I still had that interest in sports, orthopedics, that kind of thing. We didn't have one here. But one of the docs who was here at orthopedic program wanted to start one. So I started to work with him on starting one. And at the same time, I was offered a job at a private practice here. So I started there, and 2 things happened. Number 1, the fellowship never really worked out. It fell through. So that program didn't start. Number 2, I found I really enjoyed the job. And so it was a combination of factors that led me there in the end.
Yeah, that story is a very common story, almost with every single medical student that rotates through my office. They start with surgery, orthopedic, rehab, internal medicine, blah, blah, blah. I almost never, ever find a kid that comes and says, yeah, I want to do general peds.
David, I'm curious to know more about Panorama Peds.
So we've been around since about the late 50s. So it's been around for quite a while. Started off with 3 guys who finished training here in town together. I think one of them was in the military for a little while. They came back, they started a small practice, the 3 of them, and it's just been growing ever since, basically. They hopped around to a couple of offices the first 20 years or so, 30 years or so. And then we landed in our current office. They built that, designed it, and moved in 1991 or 2, somewhere thereabouts. So we've been in our current office for 30 years. In that time, when they moved in, they had 4 docs. Now we're up to 9. So we actually, just over this past year or 2, decided we've grown out of the space. So we are actually in the process of building right now, or we're going to be moving in probably December of this year with the new office.
That's a little delayed, right? Because I was hoping I was going to see the new office.
Yes. Yeah. You know how the build.
How many rooms are you going to have in the new office?
Was I?
How many rooms will you have in the new office?
33.
33 rooms for 4 people?
Oh, no, we're up to 9 now. Yeah. So we have 9 docs and 6 nurse practitioners.
Oh.
So on any given day, we'll have 9 to 11 providers in the office at any given time.
Oh, okay.
So we scaled it to be just enough for our RP's day to have 3 per provider.
Yeah.
And when we interviewed Sean Lovichuk, which is a cardiologist in Long Island, he said there are 3 things to be successful: ability, affability, and access. I think he used another word. And you're very affable. I'm sure you're very able too. But how do you do that access? What are your hours? And why do you think that's important?
It's a huge thing, actually. When I do prenatal visits, I always ask, how'd you hear about us? And what good things did you hear? That kind of thing. And that's one of the first things our families always say. And it's what they tell their friends when they're having new babies is, oh, we love the hours. Some of this is, because of our size, because we have a big staff, or we're not torturing any one person, never say, we have enough people to rotate through hours. So Monday to Thursday, we open at 7:30 and we're open till 9 p.m. And then Friday, we close at 6, and then we are open Saturday and Sunday mornings for urgent visits.
How many people are working until 9 p.m.?
Usually 2, usually a doc and an NP. Yeah. So what we do is we flex that too. In the summer times, we'll fill those evening hours with more physicals.
Right.
And now, as we go to fall into the winter, we will flex into having less of that booked ahead of time so that we can do more illness visits in the evening.
Interesting.
You were telling me last night that 7:30 appointment is always booked.
Yes, very much. That's one of the things as I've come into more of a managing role on, and one of the things I've wanted to do is, as you can imagine, in a big office like ours, there are some things that have lived on just because they are. And so I have wanted to rethink everything from the ground up. And one of the things I had thought of is to be good at 8 to 9 or something along those lines. Do we really need to open at 7:30? We do have some staff that drive in from quite a distance. And so it's a little bit of a stretch to get there. Again, honestly, I'm not a morning person. When I broached it a couple of times, the office staff all told me, don't you dare. The patients love those hours, probably even more than the 9 o'clock, the PM hours, because they can get a kid in, get them seen before the start of their day. And they made the point, they asked me, they said, has your 7:30 slot ever been open? And I was like, no, you're right. And I've been at this practice now for 10, 11 years. That 7:30 slot is always booked. So I had never thought of early morning being an important part of the access, but it really is. It's very much used.
Very important to people. Now, you became managing partner after being the IT guru for the practice.
Mhm.
What's the top one thing a managing partner needs to know and why?
Yes. Yeah. So, and this is recent too. I came into the practice actually specifically as the IT guy because I had spearheaded the EMR of a previous practice. At Panorama, their doc that had done the same thing, we had actually worked together when we were each trying to decide the EMR for our respective practices. So I knew he had hit retirement age and I was looking for a new place. So I stepped in as he stepped out. So I came in as the IT guy to this office. And then just within the last year or two, we had a reshuffle and decided to kind of solidify our roles and really have someone have the clinical director role, have someone have the operations role, someone have the finance role, that kind of thing. But we had always had a managing partner and that person was stepping down. So I stepped into that role. And what we did is we dovetailed. In 2023, we shared it. And now here in 2024, it's me. So this has been an interesting experience for me. And I'm going to be answering some of these questions as a little bit of a sophomore for myself. But from what I've learned so far, the very, very first thing I think that has hit me is know yourself. Of things you need to know yourself. We all have management styles. We all have strengths and weaknesses, and you have to know those things. And as you manage also on some level, you learn those things. And so that helps you to, you work to your strengths, but also work on your weaknesses in a sense. For me personally, for instance, I am about vision. I'm about planning. I'm about big picture. I love those things. The move that we're making now was, in a sense, that was my idea because we were about to sign a new lease at our current place. And it was almost going to happen automatically. And I was like, whoa, wait a minute. Is this the right thing for us to do right now? And maybe this is the time to look for the space. So I love that thinking. The flip side of that, for instance, I am not a good HR guy. When it comes to staffing issues and things along those lines, conflicts, that is not my forte. I don't have that. I don't have that soft hand with those things. And so I've had to learn a couple of things. Number one, delegate. And actually, we're going to talk about that more in one of the other points. But also, number two, you can't, as the managing partner, one of the things I've learned now is that truly all of the bucks stop with you, even if you have someone else. So we have someone in the operations role and they take care of the HR, the staff, that kind of thing. And we have an office manager who's also in a sense under them or works with them. So there are people who do that, but I'm still the backstop. So I have found over time that, okay, I have to work on that. I don't have those skills and I have to work on those skills. So you very much have to know yourself to be able to manage effectively.
Yeah, I've learned over the years by interacting with physicians and talking to them and so forth. A lot of physicians, especially the old generation, they were terribly good at micromanaging everything. They got to the point where they micromanaged so much they couldn't really function anymore, and they bring down the practices. They get involved in what brand of toilet paper the office is going to get. You know, you have to learn to delegate. That's a hard one. Delegation is a hard one.
Yep. So it sounds to me that you have a very clean vision of what a management structure is. You're the CEO or the president of the company. Your job is to set the vision, the mission, and the values and make sure everybody across the organization follows that. And then you have that duad, which is very successful, which is a chief operating officer who implements that vision paired with an administrator that covers the blind spots of a physician that was not trained to do. We didn't go through an MBA, George did, but we didn't go through an MBA to learn about human resources or finance or accrual versus cash basis. Those are things that we know tangentially, but we don't really have studied in depth. And we see it over and over that the healthcare organizations that are successful usually have a very strong vision and somebody that walks that talk, and then a good operations team that makes sure that that vision gets implemented. So it sounds like that's what you're doing, and that's your managing style.
Yep, I would say very much. And part of this too is from the experience of the practice also, because George, to your point, for a long time, you just had a managing partner and all of the bucks stopped with them. And we burned a couple of them out. We had just grown too big for one person to manage everything and then practice medicine at the same time. So we finally came to the point where we decided, all right, we do need, and it had always been that, so in our practice, everyone who comes in and stays becomes partner. Okay. And it always been understood, everyone helps with the managing of the practice, though there is also one managing partner who's the boss, right? The problem with that, not having structure under the managing partner is too much of it would then flow to that person, to he or she. And they were just getting burned out. We burned out one, and we burned out a second one. We finally said, we can't keep doing this. So we've become big enough that we need more of a structure underneath that. And so that's exactly what we've done is we have an operations officer, we have a clinical person, we have a finance person who works closely with our business office manager. There's someone who's looking over the books and the revenue flow and stuff like that. And it frees me up to be a little more of a quarterback and bigger picture thinker. And so it is. And I think this all depends on the size of your practice. And a lot of this was in point number 3, actually, when we get further down. It scales up or down, right? You might not need 5 people. You might only need 2 or 3, depending on the size of your practice.
Yeah, but not every physician is partner material.
True.
It's hard to find that partner material physician.
Yeah.
And then if you find them, they need to be mentored and taught what to do.
Yeah.
It just doesn't come in, you get the big bucks now and, you're a partner and you go see patients.
Especially now, people don't want to run a business. I was going to ask you, how much structure time or set aside time do you have for being the managing partner?
2 hours a week.
2 hours a week?
Yeah. It's not much. Yeah. So what we decided to do is we went with a combination. We had this was a big change for the practice. And so we had a lot of sit down sessions of like, how's this going to look? It'll allow us to continue to see patients and bring revenue. And so we had those discussions of, do we take extra compensation for these roles? Do we take time for these roles? And we have taken a mix of both. So each of the partners who is taking one of these elevated roles gets also some upfront salary in a sense for that per year. That doesn't have to do with how the practice did with revenue during the year or anything along those lines. And then a little bit of time for admin time.
Oh, well, the 2 hours a week doesn't sound enough.
I've become very efficient.
You have to bring you to work at home.
I'm sorry?
I'm sure you do partner work at home
After hour. Absolutely, yeah. So that does not all happen in those 2 hours. That's without a doubt the case. Yeah.
How often does the partnership meet?
Once a month.
Once a month.
Yep.
Okay.
Yeah. So we set aside a once a month meeting. And what we do is it's a 2-hour meeting. And the first hour we meet with everyone, with the nurse practitioners. And it's more of a clinical meeting where we have one of these tomorrow morning, actually. And someone from Peds Infectious Disease over at the hospital is going to come over and talk to us about some of the studies they're doing. So our first hour we do as more of a clinical check-in. We'll do some education, those kinds of things. Then the second hour is when we do our management stuff. So we meet once a month. And we try to also then do more of a longer retreat once a year where we'll do like an evening together. With influence right now of all of our docs, the kids are all hitting middle school, grade school, high school age. It's getting harder and harder to get those together. But we try to have a once a year bigger sit down.
And what do you think is the second thing a managing partner needs to know and why?
So know your practice. All right. So and the idea behind that being get data, right? I think of it this way, just as think about baseball. So my Mets are in the playoffs right now, right? Somewhat surprisingly to me, I didn't think they were going to make it. But you think about baseball statistics, right? You see one player and you find, they have a batting average of 240 with 34 home runs and 90 RBIs. You go, oh, that guy's a slugger, right? And then you see another player and they bat 320 and they have 5 home runs and 80 stolen bases. You go, oh, okay, this is a leadoff batter, right? So you need to know your practice. These things one of the things I found is there were things we didn't know about ourselves until I started to run the numbers. And there's 2 things about that. Number one is it can sometimes change your perception, some of your decisions. And so, for instance, I having been one of the newer guys, they were feeding me a bunch of prenatals. They were like, oh, the new guy's got to build his practice. But I've said earlier, I mentioned I was taking over for someone who was retired. So once he left, I got all of his patients. And then I was also being fed the prenatals. And no one was really looking at who has how many patients, like what size are our patient panels. And I was feeling like, I feel like I'm really busy, like almost too busy. And I finally ran, being the IT guy, I was like, oh, I have access to this stuff. So I ran the numbers. And whereas they were trying to fill me, thinking I had to fill my practice, I had the biggest panel of everyone. I had to go to them with the numbers and say, whoa, Nelly, we have to slow this down. We have to redistribute. I maybe the new guy, but I'm not the empty guy.
Or you might need to hire another clinician because you got too much growth and you don't want to lose that opportunity.
Exactly. You don't know those things until you see things down on paper. This came up, for instance, with our loop as we started to look. Everyone knows that if you move too far, you're going to lose a segment of your population. Right. So we really worked hard to find something as close as possible. And so we actually were only moving about 1.5 miles down the road from where we are now. But it's interesting because it was in the direction that a lot of the staff had in the sense, oh, we're moving away from a lot of our patients, the town where we thought our patients were coming from. Once again, I ran the numbers and I was able to put it down on paper and show them, no, actually, look, you guys think that these towns are where all our patients from, but our top zip codes are actually here and here. And we're actually moving a little closer to them. And that's actually borne itself out as I've been talking to my families. I would say 80% of them say, oh, we love it. As a matter of fact, it's a little closer for us. And without the data, that wasn't the impression. The impression was we were moving the wrong direction, but it turns out that wasn't the case.
With a new practice move, I learned twice, if you build it, they will come. Make it really fancy and give them good access, you're going to outgrow the space already. Now, I saw that you guys already have a lot of providers. How many patients do you guys have?
I think, right, most recently when I ran the numbers, we were smidge over 13,000.
Oh, wow.
So yeah, so it's a good size practice.
Yeah.
And second point about the data, right? What I have found is probably most important as a managing partner. It's not even so much a point in time, but the trends, right? And so it's not just get data, it's can keep getting the data, right? Because that's one thing that says you run your numbers and you find, oh, we have 5,000 patients. Right? Okay, that's good. But what's really more important is knowing that last year you had 4,800 or last year you had 5,200. Right. And now you're down. Oh, why is that happening? Because those things, you watch the trends, then you need to, okay, we need to drill deeper into that and find out like, where is this coming from in a good way or in that way? It can be both ways. I drilled down into at one point, because I've talked with a lot of the staff about, we've been growing and it's a blessing and we aren't doing anything. We don't advertise. And so I put a question, we have a prenatal questionnaire we have our parents fill out. And then I added the question to it, how'd you hear about us? Thinking, just to know, like, where's these streams coming from? Is it a certain OB practice that we should go visit and make sure they keep sending us the patients, all that kind of thing? And I had them to take the first 100 of these and put them on my desk. And I went through them and 97 of them were word of mouth, family friend, family number, that type of thing. And that maybe 3 or 4 or 5 where I Googled you guys. So it's, a lot of it is just organic growth, really.
And I just need to teach you how to drink bourbon and then sit down with Chip Hart and me and go over these things because you're a data nerd and all data nerds drink bourbon.
Yeah, I know. I guess I have to work on it.
We talked about this because this is not new to our specialty. The old guys used to, remember when we used to do 1, 2, 3, 4, and then cross, 1, 2, 3, 4, and then cross on paper? The old guys did exactly what you did, but they didn't use, and now I'll have another comment, but they used to count the newborns every month. 1, 2, 3, 4, cross, 1, 2, 3, 4, cross, and keep it on a piece of paper on their desk. And then they would not release any record for transfer to another practice until they looked at the record and saw who it was that was transferring, where they were going, and they would count them. And so every month they knew how many patients came into the practice and how many patients came out of the practice. And that's how they knew if they were doing well or not. And today you said you use pivot tables. I had to tell you pivot tables are a 1900s tool. We need to get you to some data analytic platforms.
So what EHR are you using? What technology are you using?
We are on MedEnt, actually.
MedEnt.
Very much a regional EMR. They are out of Auburn, which is a little bit east of here, close to the Syracuse. And so you go somewhere, there's Texas, California, and probably never heard of the thing.
Right.
But they really oriented themselves towards smaller private practices. And so if you talk to a lot of the pediatricians, family practice up here in upstate New York, they've gotten a little bit into Ohio, Pennsylvania, New England a little bit, but it's a very popular platform up here.
Yeah. So sounds like you're doing a lot of spreadsheets and
Yes.
since that way.
Yes. So that's what I'm having to do is I take the data, dump it into a spreadsheet, and then manipulate in there. But the EMR itself, I'm able to extract data very well, but not manipulate it within the EMR. So I have to do that.
Right. Yeah. Now you need to pull that stuff. What I think physicians need is they need a platform where they log in, everything's in their face, they look at it, they move on. My biggest problem is running reports, pulling them out, dropping them down, uploading them to get that pretty dashboard.
Yes.
And it's running the reports that's the problem, because nobody runs them for you.
Yeah, exactly. Yeah.
On our dashboard, we measure exactly what you're saying.
Yeah.
We measure what the total panel is, and we've arbitrarily said 18 years of age is where we measure. Some practices keep the kids till they're 25, but you have to be consistent. So when you're looking at different practices, you're measuring the same things. So we measure all the kids, how many 18-year-olds are in the bucket for this year versus how many newborns are coming in for 2024. Because if you're not replacing your 18-year-olds with the newborns, you're shrinking. I have this disagreement with George all the time. I'm a big believer in marketing, even if you're growing, because the importance of a business is to keep it growing, keep the revenue coming. You should always be marketing, even if it's mostly word of mouth. Brand awareness is big and it's not very expensive anymore. Now, the hardest part about marketing is when you're not doing well, is to spend the money to market or in the cash. But that's the summer months when there's no sick visits. That's when you should be doing really heavy marketing to get all your well-child exams coming in to keep the volume on. And it's hard because that's not where the revenue is being made. The revenue gets made in the winter with all the sick visits. But yes, getting these spreadsheets into a way that you can visualize the data quickly is incredibly important. I wonder, this is going to give you a heartburn, but do you have a emergency plan in case Madam doesn't survive?
As far as like the company itself?
Yes.
So yes and no. Probably the natural step would be to step to Epic. The hospital system in town is on Epic. It gives the seizures thinking about that. We certainly would look into some of the other, I know there are a couple of very pediatric friendly programs out there. We would absolutely look at something like that first.
I lived through one of these times where our EHR just died, was bought over by some company, and they killed the product. The product was really good, but I felt something was coming up, so I started to demo other companies. I've seen a lot of EHRs. The only EHRs that any pediatrician should look at is either Office Practicum or PCC. Forget about Epic. Epic is hard. If you want your production to decrease 50%, choose Epic.
Exactly. Yeah.
Yeah. It's always good to have contingency plans.
Yeah. So I was ready when they dropped it. I already knew where to go. I just had to make a decision. We went live with a new EHR. We found out on sometime in the middle of July. Decision to get a new HR and go live was on Halloween. So the middle of July, we found out, and we went live on October 31st.
Wow.
Pretty darn fast from demoing, decision, negotiating, and go live.
Yeah.
And then go live. We ended up going with Office Practicum. But you have to know something, because if you're figuring it out at that time, it's a problem.
Yeah. Yeah.
Because there's a lot of stress attached to it, a lot of problems. It's not just a physician that has to deal with EHR. It's from the secretaries to the scanners, to the nurses, to the doctors. Everybody gets affected by this, and production will come to a halt.
And you're billing them.
About that.
And as I've taken on this management partner role, I've actually kept the IT role. I live that every day. Yeah. Having to know all of the pieces of the system. It's like an 8-headed beast sometimes. But the good thing is, even at my previous office, we were on the same platform. We were on Medent. So I've been working in this platform for almost 20 years now. So they're pretty robust, and I think they're going to be around for some time, as I don't see them having any imminent issues. Yeah, just recently I saw they are now working on an AI integration. That's the big thing nowadays. They seem to be keeping up with the latest and greatest.
Yeah, we talked about that last night. This new natural language model and AI to dictate your notes. And George is a big fan.
Guys using AI yet?
Not right now.
Now there's products out there that you can turn on like in the next half hour.
Yeah.
Yes,
True.
and use it.
Having said that, one of the things, being the IT guy, to tease everyone on one system, especially now that I know that our EMR is working on integration, right? To tease everyone and train everyone on one system, especially in our practice of our size, right? And then knowing that in a year or two from now, when our EMR develops this integration, I'm going to have to retrain them on a new system. No, thank you.
Okay. That's what happens with technology. I don't know why these geeks have to make things so complicated. For pediatrics, you need something that's simple. You turn it on, you use it, you move on, and it's not crazy expensive. So in our office, we use Freed AI. Very simple. You got to use it on 2 screens, or you can tab back and forth, copy, cut, and paste into the EHR. Sounds like a lot of work, but it's not. My notes are all finalized by the end of the day. My billing is done by the end of the day, something that never used to happen before.
True.
It's easy. It's really easy. You just go to Freed AI.
Yeah.
Give an account. You get 310 charts. Then go back to the old ways and watch how you'll start crying. My doctors, but you'll find that all physicians will go kicking and screaming. And I think it's just because we're telling them to do something else. They'll say, I have templates. I have this. I'm good at this. That was me. Somebody told me about it. I refused to acknowledge it because I'm already good at the computer. I did it. Told me the second day, the same story. And then the third day, he told me, George, you really should use this because you want to go through life knowing that I knew something that you didn't. And that's what got my attention. Used it, and I called the guy and I said, dude, man, this thing is life altering. It being AI was life altering for me. And my notes are better too.
Yeah. So tell me the third thing a manager partner needs to know.
So we alluded to some of this before, but know your staff, right? And so some of this is getting a good bead on who do we have? What's the org chart, right? You should be able to draw it down on paper, right? Here's a tree. Here's who we have, what their responsibility is, who they answer to, right? And I think for two reasons, I think that's important. Number one, you need to know that all of the things that have to be done in your office have someone who's doing them, right? And I suppose you can also say someone who's also responsible for making sure that those things are getting done, right? Number two, as the managing partner, I alluded to this before, you can't do it all yourself. You need to be able to delegate. And so, so you need to, you need to know, but also make it clear, right? It's fairest. It is least to the least stress down the line. If everyone knows their role and they're not surprised when you come to them and ask them, hey, can you do this for me? Because you have laid out ahead of time that this is your role, this is your responsibilities. I'm a big fan of, in the business world, George would probably talk about this better than I can, this RACI model, RACI, right? Who's responsible, who's accountable, who's a consultant, and who just needs to be informed, right? So there are people who have to do the work, so let's say there are, maybe you have for instance, we have one nurse who kind of rotates off the floor. We have actually a couple that rotate off the floor each day, and they take care of a lot of the medical and the stuff that come in, the school forms, some of the phone calls, the prior authorizations, stuff like that. They're responsible for that on that day. But the nurses on the whole are responsible for those things. Who's accountable? We have a nurse manager. So she is the one who needs to make sure that those things are all getting done. Consultants, the C, right? For instance, I'm also still the IT guy. So if they run into something where they go, I wish the EMR would do this, or is there a way for that to do that? They come to me, right? I have a side expertise that can help them in their role. And then the informed person, the person who doesn't need to be involved, but just needs to know that, all right, this stuff is getting done, or we're having XYZ issues, that kind of thing. So that would be the person level up, right? So if there is, let's say, an issue with the front desk and the business office figuring out who is going to take copays, let's say, or something like that, right? Our office manager needs to know that, we're trying to figure this out. But she doesn't necessarily need to get dragged into the figuring out at first, right? She just needs to know, this is an issue and we're working through it. Because that's, you need, as the person there, you need to know that these things are going on, because you need to quarterback, right? And you need to be able to say, let's get this person involved. Or, that's a question for the partners. Let's ask them whether they want us to do X, Y, or Z. So you need to have a feel for how are we structured to be able to manage.
Yeah, I think that starts very early on, and there's a Greek book called WHO, WHO, and a system on hiring employees. And the first thing that you do when you're trying to hire an employee is you build a scorecard, and you hand it to the person applying to the job. And you say, here's your mission at this job, whatever it is, front desk person. And here are the things that we're going to be measuring to see if you're doing your job or not. And that then you start hiring with the right people, because if some people are shy about asking people for copays and money. It can't be in the front desk, because that's part of what the front desk does. It collects copays and deductibles. And then the other one is the 4 disciplines of execution, which is basically how to lose weight program. But it's an account system where you have big goals that they call lag indicators, like your weight. By the time you gain or lost weight next week, it's too late to change. And then they break it into SMART goals, which are things you can do every day that will actually get you to your overriding goal. And so, for example, we're talking about weight. If you walk a couple more steps and you stop sugary drinks, your weight's probably going to drop next week. And then you have very short meetings where you ask, hey, Herb, you promised you're going to walk 2 blocks every day last week. How did you do? Oh, I can only walk 3 days. Why? Because it rained 4. What are you going to do this next week to catch up? I'm going to walk twice as much this week. It's going to be sunny the whole week. Great. I'm going to write that down and then we're going to talk about it next week. Where's your weight today? That's up. That's because you didn't meet your goals. So we got to correct that. And the meeting ends. That's it. It's just, what were your short-term goals? And did you accomplish them? If you didn't, what are you going to do to accomplish them this week? We'll see you next week. And it's a fascinating, very simple. It's the same thing as we do with weight for our patients. It's break it down to little steps so people can be successful, not wait till they've gained 5 pounds to then go back and say, wow, you should have done this. But yeah, that scorecard is very important, that system to move up the chain so that you're not doing that. You just know what's going on. Otherwise, you can't manage. It's so big.
One of the things we ran into too, I think, is that there had been a point where we had that kind of system, not to that extent set up, but COVID exploded a ton of this stuff. And I still feel like the last year or two has been a process of, oh, we have to get back to doing this. Oh, we have to get back to doing this. We're 3 or 4 years out now, and it's finally feel like the dust is settling, and we're finding that, oh, there's these things that had been a thing before COVID that became impossible to do for that year or two. Then now we have to be intentional about, oh, we have to start doing that again. It's too easy to let those things slide.
And what is your company's mindset on employees? What if you have an underperforming employee? How long do you carry that?
We have a process, right, of if they're underperforming, that we have if we can go through a process with the office manager of, here's the ways why, here's what we've been to do to help you. And then she'll meet with them again on a regular basis. And so I think that's probably one thing that we do right now is, I think the shorter frequent meetings right now happen more when someone is being helped along. They're done more reactively than proactively. And that's probably something that we need to work on. Interestingly, one of our docs has a little side gig at a medical tech firm. And he's brought that idea over from there, that they do a lot of this in their process as they're doing their programming and their all that kind of thing. They do a lot of these short, frequent check-ins. And so he can see it in action there. So I think he's going to be the resource to help us along here. But it's one of the things I've learned also is that, like I said, HR is not my strong point, but I have found that some of our office management, they have done a good job of being flexible with some of these things. And for instance, we had a couple of employees who maybe didn't start off in the right position for us. But over time, we realized that, you know what, you actually might do really good in this position instead, and gave them a sidestep and found that they were then really happy in that position. And so flexibility is we are a big pediatric practice, but we're a small business overall. And I think on some level, we also have to think of ourselves as what's an advantage we have should be being nimble in those ways. We should be able to make some of those changes and do some of those things and act like a small business, not like a big business.
And what is the fourth thing a managing partner needs to know?
The finances, know the money, right? That's what makes the world go around. No margin, no mission, right? So you really need, this is, I guess, a little bit of a 2A from the data, right? Because since it's also data, but it's very specific data, right? So you really need to know, what are your revenues? Where are they coming from? What is your percent of T14s? What is your percentage of your practice that takes each specific insurance and how they bill? And what are your costs? What are your outlays? What are your staffing costs? So what are your vaccine costs? You need to know the ins and outs. George, you had mentioned micromanaging, right? Yep. That's one of the things I find is an interesting balance to find is I think bigger picture, And I find a lot of the business office staff tends to think smaller picture, and you need both, right? You can't just have the one, you can't just have the other.
Yeah.
So that would be a blind spot for me. If it were me, when we get our quarterly reports, I would put it in 3 or 4 categories. Here's our costs this quarter. They have it broken down into maybe 15 or 20. And I look at that and I go, I don't need that granularity. And so I sit there and I take clumps of them and add them together so that I get bigger categories. But down in our business office, I say down in our business office because right now they're a floor below us at our current office, but they pick up on things that I might not have seen those signals looking at the bigger categories. So you have to know these numbers 100%. I think 4B to this also is have someone backing you up. So we have a fantastic accountant / business consultant who works with other practices such as ours, other kind of independent like law firms, other small to medium-sized medical practices. So has a lot of experience in businesses of our size. And he has been, without a doubt, integral to our success.
And are there 2 numbers that you watch, like days in account receivables or your percent of AR over 90 days, or there are 2 numbers that you like to watch and see where the practice is going financially?
So it's a great question. And I think, I don't think you could pick 2 really, because I don't think 2 is enough to really give you a full picture of what's going on. For instance, I'm a big fan, honestly, of visit counts. It's such a simple thing, but I think when you're looking at accounts receivable, certainly days in AR over 60 days or 90 days, very much that stuff is important, right? You need to make sure you're bringing in the money that you earned, without a doubt. I think looking at how your different payers are paying is important. And once again, this is one of those trending things, right? Which of our payers have inched up their payments over time, which ones have kept it flat, et cetera, et cetera. Those things are important. But truly in the end, if a payer pays me 5% more this year versus last, if it's $100 visit, that's another $5. But if I get another visit, it's another $100.
Right.
So honestly, yeah. So I think, you can look at percent for 99214s. You can look at accounts receivable. You can look at a lot of these things. They're important to look at, very much so. I find more so because, once again, trending, right? If one of those starts to fall off a cliff, you have to catch that. That's going to be a thorn in your side. Yeah, but I find really, truly what tells me the health of the practice is visit counts. Are we bringing people in?
All right. And then what's the 5th thing a managing partner needs to know and why?
Know the future. And yeah, I say that a little bit tongue in cheek because no one has a crystal ball. But as a managing partner, I part of why, as we had these discussions of, all right, we're burning up managing partners, we need to really have people take some of these sub roles and be lord over finances and lord over clinical and that kind of thing. It's so that I think, and honestly, unfortunately, where we've come in pediatric care, right, our margins are getting squeezed over time. Right? Our payments are not keeping up, not even compared to adult interests and whatnot, right? We're as you guys have seen the numbers too, right? As of the last several years, we are the low man on the totem pole. The problem with that is that you hit a point where you're just putting out fires, and life becomes putting out fires week by week, month by month. And that doesn't allow you to think forward. Sure. You're always just covering your tail. You're always just surviving and not taking that time to think strategically. And one of the things that we decided as a group is that's important and we need it. And we need to subdivide some of this stuff and give autonomy. So actually, it's my colleague who was the managing partner actually sidestepped into the finance role now. And so I can trust him that he was looking at these numbers, right? And sitting down with the business office monthly and quarterly and watching these things. So I don't have to watch it as tightly as he is because that's his job. And he's coming to me and letting me know, hey, here's how things look. That frees me up to quarterback. So he comes in and says, oh, hey, here's how the things are looking. It's been soft. We really should look at bringing in more visits. I can then turn to operations and clinical and say, hey, you know what? We need to work those overdue well tab lists. And that's good because with things gotten soft, we have space in the schedule. Let's go ahead and do that. So that allows me to think bigger picture and think, oh, okay, what can we do about this? Okay. But B, also look forward. Where do we want to be in 2 years and 4 years, 5 years? And there is no crystal ball. You need to at least have even if you have a plan B kind of thing. And
Where do you think you're going to be in 5 years? You're not ready for retirement.
absolutely not. Absolutely. I'm not being
going to be. I think you're going to, I'm sure you guys get hit up every other day by private equity and hospital systems to take you over and so forth. Now that you got a brand new shiny office, it's going to be even more common.
Absolutely. Yeah. It's interesting that the pediatricians are the last frontier here in town for the local big organizations, for the hospital systems. They have taken up some of the OBGYN offices, most of the internal medicine offices, only just a couple of the pediatric offices. I don't know if that they see that we're not big margin money makers. There's also always been a more collegial relationship between the private peds and the ivory tower peds than there has been in the other areas of medicine here in town. So maybe that's playing a role. I don't know. This is one of those things where I haven't necessarily been in the room where it happens, right? To quote Hamilton. So who knows what's going on behind the scenes here? So those things really haven't from the past up to this point. Are they going to in the future? I'm sure they are. All right. I like to say, this is where the trends are going. And so what does that mean for us? So right now, like I mentioned before, we're moving to this new shiny office that has taken up all the oxygen in the room. So, but I think, we move into this office, the dust settles. Those are definitely the next discussions we have to have of what are we going to do when those people come knocking and how long go ladder. Sorry?
Kick them out. Don't answer the door.
Think first, right? Exactly. Yeah. But I think having been around for so long, we definitely have a little bit of an intense independent streak. But I think we very much want Panorama Pediatrics to stay Panorama Pediatrics and not be owned by anyone but us. So then if that's going to be our strategy, how are we going to do that? How are we going to survive in this current atmosphere? We had mentioned how we just really have organic growth and we haven't had to go out and seek that. The other thing we talked about when we made this move is we did a lot of discussions about, do we want to open a satellite instead and spread in that direction, right? Rather than go with one bigger place, do we want to start to spread geographically? This time we decided not to do that. But this is, like you had mentioned before, this is a pretty big office, 33 exam rooms, room for 10, 11 docs to operate at one time. If we were to continue to grow, that's the other thing we run into up here, upstate New York, Monroe County. We're losing population. We are not only is the birth rate creeping down, but people are leaving for greener pastures. All of these schools, rosters are slowly going down over time. So that's also something that we have to look at and say, okay, what are we going to do with that? How are we going to manage that? How much more do we think we can actually grow, especially being in one place? So this is the current. 5 years down the road, is this going to mean, I don't see us growing any bigger in this space, right? So does that mean, do we start to do a satellite kind of thing or something like that? It's a valid question. We've lightly had those discussions, landed on move to a bigger office. That's about as far as we got.
A couple of questions are very local to your market. How can you survive with one health plan on 70% of the market?
It's a very unique situation up here, without a doubt. But the more I got involved, it's interesting. Once again, with our margins being as thin as they are, I don't know. I'm very much, my undergrad degree actually was an interdisciplinary degree. It was called Health and Society. But I did a lot of public policy, medical economics, this kind of thing. That was my undergrad degree. So I'm very much actually a free market guy. And so my first impulse is, oh, having a monopoly like that on there, and this is terrible. It handcuffs us, right? Problem being, though, I think more the issue is the difference in size. It's the David and Goliath between us and a company we might want to negotiate with in some way, shape, or form. Because I think to myself, let's say they only had 25% of the market. That's still too much of a share. I think of the way our margins run, let's say they were only 25% and we said, we need XYZ or we're going to drop you. And you don't want to say that unless you're intending to do the thing. Right? So you have to be willing to then drop them. Let's say we drop them and half the patients left, that would be 12.5% of our practice. Couldn't we even weather that? I don't think we could. I think it's telling. There's been a few practices that have stared them down over the last 10 years, I would say. It's always been a specialty. Right? There was about 10, 15 years ago, it was a plastic surgery group. More recently, it was, I think, a radiology group, if I remember correctly. And so it's never been a primary care group that's done it, because you think about those practices, they're making enough money that they can take a little skin off the end of their nose in order to go through that negotiation. And I don't think we wouldn't be able to do that. There's no stomach for it. But I think part of it too is our Medicaid payments here in New York State are very low. So yes, there is one company that has quite a monopoly here in town. They aren't a horrible payer. They're not our worst. They're not our best. So it allows us to operate. If there's a lot of talk about, we should go Medicaid for all. That would happen here. If that were happening here in New York State, we would go under immediately. There was no
thoughts on that, Herb?
and just no way we'll survive.
We just triggered him.
So
1 minute. Tell us your thoughts, Herb.
I think the American Academy of Pediatrics, as it often does, has no clue how the real world works. And I'm not good with language, but they're incredibly idiotic with language. The last thing you want to put on a paper is supporting the senior senator from Pennsylvania who's proposed in the Senate that every child be given a Medicaid card at birth that can't be taken away till they're 18 without any payment reform. If you do that, hospitals, pediatric practices, maternity wards, pediatricians will all cease to exist in America, and no one will have access to care.
Already happening.
You should be very careful when you say you lead pediatricians and you care about access for children in the words that you put to a paper and publish in a journal. And Medicaid for all is not supported even within the American Academy of Pediatrics by the people that are insightful and in leadership roles. That paper should have never been published, not with the title.
Thank you, Dr. Bravo.
Well, the next question is,
here's the thing too, right? A tangential conversation to this is this whole idea of value-based care. We need this new system, and that is what's going to save pediatrics and internal medicine. And the thing is, I remember, I can't remember if it was either Partial Lesson or Chip Hart, one of them made the point. They said, it doesn't matter what the system is in the end, as long as the payments are set appropriately. You can have 5, 10, 15 different systems. The payments, they're just a system, right? And in that, you're plugging in somewhere in there, you have some sort of variable that is going to be a base rate that is going to affect all the other payments. And no matter what the system is, that could be set high, that could be set low. So you can change the system 5 different times and we can still not come out in any healthier of a place.
Even right now, they're talking about value-based contracts and payments and plans and so forth. You know what? They don't work yet because they still don't have enough money allocated in the budget for children because they don't care. It all costs money, so they don't add money into the budget.
I think I push back about they don't care. That we all care about what's causing us pain right now. So the government has a problem because they have to take care of either people who are absolutely disabled that need care now. If you're in a nursing home because you're a quadriplegic and you don't have a dime to your name, you can't be set on the street and say, okay, you're going to die, but who cares? You can't do that. Not in a society that cares. You can't leave elderly folks that are dual enrollees in Medicare and Medicaid and are either heavy on home health or in a nursing home, very debilitated, kick them out on the street and say, okay, fend for yourself. You're going to die in the park. That's okay. Those are real pain points today. So the money goes there. And I have to separate it. And you have to say, we need to spend more on prevention. And that's not hurting us today. The knee doesn't hurt. But if you're not watching your weight, you're not exercising, it's going to hurt 20 years down the line. And you're going to spend a lot of money. So when you say value-based care, doesn't work because preventive care is about investing in the future. And that asks that as a society, we figure out how much are we going to invest, who's going to borrow the money for the investment, and how are we going to pay for it? It all comes out of our pockets one way or another. But how are we going to pay for it? Are we going to do a tariff in hospitals and health plans? Are we going to increase people's payroll taxes? Are we going to increase the federal taxes? So we do this. Do we increase property taxes in the communities like they do schools? That's how they fund it. But that's a real conversation. When you hear these people talking about fee for service and value-based, they're morons. And all they have is a bunch of talking points. And they keep circling around the same talking point, throwing it in ChatGPT, publishing it on a LinkedIn profile, and thinking that they're geniuses. That's not the problem. The problem is we haven't answered the fundamental questions. How much do we invest in our children? How do we finance it? And how do we find a pay for it? No one wants to have that conversation.
Correct.
It's a real conversation. Annie, I was going to ask you one more question. All right. What is the disadvantage of a duopoly health system in a community?
It's actually, so I've seen this. So I came here for undergrad and I've been here ever since. All right. So I did my medical school here, residency here. So I've seen the system here in town for a good 3 decades or so. And it's been interesting to watch it. I wouldn't even call it a duopoly anymore. It's more of a 1.5-opoly, because go back 20 or 30 years ago, I would say it wasn't duopoly. And honestly, that had advantages, to tell you the truth, because there was the ivory tower, and there was that hospital system, and they had their staff, they had their specialists, they had their clinics. And then we had the community-based system. They had their main hospital. They had a couple of side hospitals. They had their set of specialists, et cetera, that kind of thing. But they each had a lane. And the ivory tower did a lot of the specialized care, the cutting edge stuff, the research, that type of thing. In the community hospital, did the bread and butter. So back 20 years ago, when I first came into practice, if I had a kid who, it was 10 p.m., they call me on the phone, and the mom was, he's having an asthma attack, I would often tell them, go to the community hospital emergency room. They had a fantastic, as pediatric residents, we rotated through both. The community hospital had a smaller peds program, a smaller peds ED, but they were fantastic at what they did. They had a smaller floor than the academic hospital did. But for your fractures, your appendicitis, your asthma exacerbations, they were fantastic at that stuff. They stayed in their lane and they did it well. And the academic hospital stayed in their lane and they did it well. So actually the duopoly, I think that fondly, because it really worked. Somewhere over the last 10 or 20 years, they both tried to start to eat each other's lunch. They both got out of their lanes, and the community hospital tried to get into more specialized care. And the academic hospital tried to get more into the bread and butter and take things over and stuff like that. So what had been an understanding turned into a competition in a sense. And truly from what I see, once again, I mentioned this before, I'm not in the room where it happens. So I'm sure there's a lot going on behind closed doors over this last decade or two that I'm not privy to. But as the outside observer, it seems to me that the main hospital system, the academic system, is slowly but surely pretty much taking things over.
But that's had some real world implications, right? So at dinner last night, we are talking about screening kids for diabetes.
Yeah.
And there's no LabCorp and no Quest in Rochester. So you have no options. If the big health system doesn't decide to do the test to screen for diabetes, the kids don't get access to care. And because there's no competition, no one does it. Everybody else in the country can just go to their Quest office or LabCorp office and get it done. And I'm sure there's many examples of the same. Because there's no competition, the big hospital says, what do I care if I'm going to screen for kids for diabetes or not? That doesn't really make money for me. Neurosurgeon makes money for me. Cardiovascular makes money for me. Orthopedics makes money for me. Cancer care makes money for me. Why should I even be bothered by that? And that closes access.
Yeah.
It's not good medicine. So it's very concerning. It's very concerning. And the feds are asleep at the wheel. I am a free market person, but government is necessary. And that's why the feds have the power to bust people that are behaving in monopolistic ways. And it's antitrust law. And they have stopped enforcing antitrust law in healthcare since the Obama years. And that has not served us very well. I want to be mindful of your time. Thank you so very much for last night and for this morning. I really enjoyed spending some time with you. And I hope to see you again soon.
Thank you very much.
Likewise, thanks for having me. It was excellent. Good to see you guys.